I would like to thank Dr. Roy Chetty and the Narayana Foundation for this very nice invitation. It's really a pleasure to be here with you, sharing some of our knowledge and also learning with you how to improve our results, mainly with the contura. The purpose of my talk would be to compare the contura vision treatment with other technologies that we have available, and I will also like to share with you some of our own results with the technology that we have been implementing now for almost 3 years. Okay. So, when we first realized we have a topography-guided treatment to apply in a virgin eye, our minds were a little bit afraid of how this technology would impact our results, mainly in terms of refractive predictability. And why? Because we were very used to apply the topography-guided to fix aberrated corneas, mostly from previous complicated surgeries, and that in those patients, we had to really do a lot of refractive adjustments because the high-order aberration profile that we were correcting was really, really high, 20, 15, 60 microns. But then we were applying this kind of technology, this planning, to a normal cornea, and the normal cornea is supposed to have very few aberrations. So we were delivered a technology, and 3 years ago we really didn't have the feeling and the knowledge of the potential that the contura can have to treat patients with normal vision. And this is the main topic we were discussing during the morning. So this path from the complicated corneas to the primary eyes is what we have been doing for the last 2 or 3 years, and it's what we will continue to do because we still need to improve the knowledge about the technology. How can we take the most profit of it to improve our patients' vision? At the end of my talk, you will see that there is a clear benefit on applying the contura treatment to all or to almost all primary eyes. However, there is still an open discussion about the contura, and the open discussion is how can we refine the treatment, how we can and should customize the treatment for each different patient, for each different eye. A right eye can have a different customization from the left eye of the same patient. But looking at the future is also looking at the past. And fortunately, for you who work with wavelight for a lot of years, we have a very powerful tool in our hands that we have been using for almost 15 years. And the powerful tool is the wavefront optimized profile. This is a paper from 2017, so 1 year ago. And as you can see, the wavefront optimized, which is, I can say, the simplest and most straightforward planning in laser surgery, can offer you very, very good outcomes. As you can see, we have 10% of patients with 2012, almost 50% of patients with 2016, and patients gaining lines of vision. Then the contura came, and the American study, the TCAT study in the United States, gave us a step ahead in the treatment. So as you can see now, you can have almost 1/3 of patients with 2012 and almost 2/3 of patients with 2016, with excellent predictability and excellent safety. And I must say that when this paper was published, 2016, so 2 years ago, there was no refractive adjustment done, no cyclotorsion control. All these surgeries were done with the 400 version. And we didn't know at that time how should we optimize the conflict between the refractive seal and the coma when they are different. These are results with no refinement at all. And even though we were not taking all the potential from the treatment, we were still getting very good outcomes without diminishing the safety issues.
Okay, right.
This is a paper published last year by the group of Dr. Rohit. This was already discussed in the morning. In this paper, you can see that in the TCAT and the wavefront optimized, you can have very similar results in terms of uncorrected, corrected visual acuity and refractive predictability. However, the authors of the study were able to prove that with the TCAT, we were diminishing, we were treating the high order aberrations in the cornea. And if we know how to use this weapon, we can improve the visual acuity, mostly the uncorrected visual acuity. Also, other platforms have topography guided or similar topography guided. This is a study from 2016 comparing the supposed topography guided treatment of the MEL 80 platform with their normal profile. And as you can see, even in this platform, the topography guided in normal eyes can achieve better uncorrected visual acuity, more patients gaining lines of vision with equal efficacy and safety indexes. And also in this paper, the authors proved that the topography guided was able to better treat coma and spherical aberration in the normal eyes. How about the contura versus other platforms? This is a study also from last year, comparing the contura treatment, topography guided treatment, with the NIDEC topography guided treatment and a wavefront guided treatment from the VISEX platform. As you can see from this slide, the contura treatment is the one who could achieve better outcomes in terms of percentage of patients with more than 20/20 unaided visual acuity, having excellent predictability in terms of refractive outcome. Here you can see the refractive outcome in terms of spherical equivalent was highest for the topography guided ablation profiles. When you compare contrast sensitivity, well, here the topography guided treatments, the contura and the NIDEC profile, were able to improve contrast sensitivity in photopic conditions, and the wavefront guided treatment was better, improving the mesopic contrast sensitivity, and this is more or less as we expected. Then comes the question, well, let's compare contura with SMILE. And this really is a very unfair game. This is a very unfair comparison. And why? SMILE is a new development, a new thing coming. And you are comparing something very, very new, very raw, with something also, with something that maybe is the most refined treatment, the contura, with more than a decade of development. Of course, here in this paper, we saw that the contura was better than SMILE in terms of visual acuity, refractive predictability, and gaining lines of vision. This is more or less what we expected, because you have a lot of things in the wavefront optimizer or in the contura that you don't have in SMILE. It can be a better treatment, but we have to take and wait for the development of the technology. This was our first sample that we presented 2 years ago. This is a very small sample of patients from 2016, femtosecond laser, all with femto FS200 patients with the contura. Our results in terms of refractive predictability were very good. And what we saw from our data is that we were getting more or less the same results of the TCAT study. So we were having more or less 1/3 of patients with 2012 and 2/3 of patients with 2016. Safety was not an issue, so we had no lines of corrected visual acuity, and we had 2 cases with loss of lines of uncorrected visual acuity due to the lack of refractive adjustment. Also, as you can see, the accuracy was very, very high with all eyes in between +1/2 diopter. This is actually my first contura case, now with 3 years' time. At that time, I did the contura on the right eye and the wavefront optimized on the left eye, because the high order aberration map was very high in the left eye, and I was a little bit afraid of applying the treatment. As you can see, the result was fairly good, very, very good in both eyes, and the patient was really satisfied. This is another example of what the contura is doing. This is the ultimate customization that you can have. In the middle, you have the pre-op topography of the patient, where you can see this very, very tiny asymmetry in the cornea, which the profile will immediately correct. This is a coma-like feature. And this is the differential map, where you can see what the planning did. So really shaping up this very small elevation in the cornea and achieving a very good outcome. And this is another case where you can see very small myopia, and still this is a coma-like shape, and you see that the maximum ablation 5 microns, so very, very small ablation to perform, and very good outcome at the end. And this is the left eye of this patient with more or less the same. As you can see here, very low value of cylinder and very coincident. And this is, I presume, the best patient to start learning the contura. These are the best patients for you to start. This is a paper that we are publishing, hopefully this year. It's already accepted. And this will be the first paper talking about the contura with PRK. So we do a lot of PRK in Portugal. We have a lot of thin corneas. So we do more or less 1/3 of the surgery is PRK. This paper will show to you that contura is an option and is a valid option using a PRK surgery and not only in LASIK surgery. I will pass the results fast. So the percentage of patients with very good outcomes is high, and the predictability is also very good. 25% of patients gaining one or more lines of vision, and only 1 patient lost 1 line of corrected distance visual acuity. This is the refractive, the accuracy. As you can see, 95% of patients ±1/2, and also with the seal, a very good outcome, 90% of patients with +1/2. What are the questions for the future? What are the questions that you may want to be answered? First, the refractive spherical adjustment. Do we have to do it? In my opinion, no, and we will see later on the cases. Astigmatism adjustment. This is the hot topic that was discussed in the morning. As it was told, the refractive cylinder that our patient have comes from the cornea, comes from the internal lens, and also comes from the coma. And this is the way, and this is the topic we are developing in order to deliver a more simple and fast way to plan the treatment. Also, there is some questions about the central cornea asphericity. As long as you perform some contura, you will see that on the tangential map, you will see a very, very tiny central spot of a little bit of hyperprolate shape. We think that this has no impact in vision, but it's something we have to look in the future. And fourth, and not least, is the data reliability. Never forget that all the plannings you are doing are based on what the technician is collecting in the topography. So you must never forget to check and validate the maps being collected by your colleague or by your technician. So when to apply, how to start? When there's a good correlation between the refractive astigmatism and the topographic astigmatism in terms of value and axis. When the high order ablation map is less than 10 microns and you see a trefoil, tetrafoil or coma pattern, and you have a very small refractive adjustment to do, and when you have very good quality data. This is the best patients for you to start with the contura. So in conclusion, I think there is a clear benefit on applying the contura to all primary eyes, and we will learn with the technology, and we will improve as doctors, learning from what the machine can offer to us, and especially to our patients to our practice. Thank you very much.